Thank you. Well, welcome back to day 2 of the Nuffield Trust Summit. I trust everybody found yesterday as interesting and stimulating as I did, and we're going to continue in that vein today. We've got 2 great sessions lined up for you today, picking up many of the big systemic issues that we touched on yesterday, but through a slightly different lens. And we're going to kick off this morning. I'm delighted to welcome Teun Toebes, all the way from the Netherlands. Thank you for travelling to be here, Teun. Teun trained in nursing, health ethics and policy, and is currently a practicing nurse, but he's also a humanitarian activist and a healthcare innovator. For the last 6 years, he's been on a mission to challenge accepted narratives we have about care and health and how we look after people, particularly with dementia. And he's committed to putting humanity back in the centre of care. Teun, quite remarkably, at the age of 21, decided to move into the closed ward of a dementia care home in the Netherlands, and he spent 3.5 years living not as a member of care staff, but as he puts it, a housemate, living amongst people with dementia, to really get a good sense of their experiences of that institutional care and how they live their lives. He's published a book about his experiences there, and we'll talk a bit more about that in a minute. Since leaving the care home, he's travelled to over 31 countries and made a film with his friend Jonathan de Jong, which has won a prestigious award in the Netherlands. The film explores different approaches to looking after people with dementia and how other countries view people with dementia. We're going to start with a short clip from that film, and then we're going to invite Teun up to hear about his experiences. Thank you. Can we have the film, please?
My name is Teun. I'm 24, in perfect health, and live in the closed ward of a nursing home. Why? I am 24, but not all my life. That's why I'm now going to start looking for answers for the future. In a 3-year journey across 11 countries and 4 continents, I look at how other countries deal with dementia and the people who have to live with it. And how can we shape society in the future for the people who so desperately need our attention, but whom we so often forget? Surely everyone, regardless of age or diagnosis, has an equal right to a good life, right?
Ja, ben je toch helemaal niet meer van enig nut.
Heeft u dat gevoel?
Ja. Dat is toch ook zo? Wat voor nut heeft het nou nog als ik leef?
Good morning, delegates. Thank you so much for being here this morning, and thank you so much for embracing a more hopeful future for people living with dementia in our society. At the age of 21, I decided to start living on the closed ward of a nursing home because I deeply feel worried about the way we look at dementia and the system we have created for them without asking people, what do you need? I was working in a nursing home for 4 years, and I asked my colleagues, would you like to live here yourself? And surprisingly, almost all my colleagues said, hell no. If I get dementia, I want to live in a different way. I want to live, for instance, with my daughter, my son. I want to live together with friends in a house we will buy, or I don't want to live. But dreaming about the future of living in a nursing home was not the reality. So COVID came, and family members were not allowed to enter the nursing home. Only we as professional carers were allowed to enter. And that was so painful. I was working there and family members were outside crying and their loved ones were inside. We would never do this again, I hope. But it showed a pattern in our system. So I decided to start living together with people with dementia to deeply understand the system which we have created. I moved into a care home in Utrecht in the center of the Netherlands. I just wrote an email to the organization with the question, am I allowed to live in the care home? And surprisingly, the CEO said, yes, you're welcome. Because we don't have a lack of money, we don't have a lack of space, we have a lack of humanity. So I was able to start living on the close ward together with, for instance, my housemate Ellie. I was living all with people with dementia. And Ellie and I, we became really good friends. I had a room, it was 21 square meters. We shared our bathroom, we shared our toilet, we shared our living room. And Ellie and I were almost always together because we really enjoyed our friendships. It was friendship with reciprocity. The only privilege I had in the 3.5 years I stayed in a nursing home is that I had the code of the door. 2017. The code of freedom. And if you visit a closed ward, you might recognize this idea that the doors are closing behind you while people waiting there who maybe want to join you going outside. And I came in, and the carer of the nursing home I was living in said to me, Teun, could you please be less close to Ellie? Because Ellie is feeling sad if you are not here. May I ask you, who of you could understand this question? Could you please be less close to Ellie? There's not a good or false. Who could understand? Yeah? Of course, I can understand it as well. I can understand that you asked to me, Teun, could you please be less close to Ellie? Why? Because Ellie was feeling sad when I was not there. When I was there, she was not having a feeling of security. So she was feeling lonely. She was feeling anxious. And she started crying. But on the other hand, I can't understand. Because isn't it beautiful that someone at the age of 92 living with dementia is still allowed and able to feel sad? That someone is still allowed and able to feel anxious. But when you are together, to experience feelings of happiness. Living in a care home, whether you have dementia or another diagnosis, it is not about making people happy. People don't want to be entertained. People want to have a meaningful life. And that's a totally different expectation, a different responsibility. When I look at the websites of care organizations, you often see happy people smiling together with a carer in one-on-one contact. The carer is sitting on her knees or her knees, tapping the other knees. The image we create to society is, come, visit us, we can make you happy. But we can't make people happy. Making people happy shouldn't be the aim. We need society for this. And therefore, dementia is not a care problem. Dementia is a societal issue in all its forms. Why? And you might be part of this as well. Almost all the analysis in healthcare start by reasoning of shortages. So we start talking about shortages of staff, we start reasoning about shortages of money, but the assumption we often have is that more automatically leads to better. But if we have more money, do we really start doing the right things? If we have more money, do we really start doing the right things? If I have an extra colleague next to me, we might not start doing the right things in order to create or facilitate quality of life. If our culture is focused on control and safety, we might write down other functional parameters instead of asking people, how do you feel? So the core of this change, it is not about new models. The core of this change is about changing our culture. And this is the most difficult we could do together. Because changing a culture, we can't buy it. We have to do this together. We have to work on this for years. step by step. And that's why I so strongly believe that looking differently always leads to doing differently. Looking differently, not thinking differently, looking differently, more fundamental. It's the fundament of our system. And I will give you a few examples based on quality of life, based on the idea that being focused in a care system on having zero risks always leads to zero life. Life comes with risks, always. Also if you're living with dementia or another diagnosis, also if you're living in a care facility. This asks from us to tell a different narrative. Living in a care facility is not a golden birdcage. We are there to help people with a good and normal life as possible. To give you an idea, this is the place where I was living. I moved in. My mom, by the way, said to me, I didn't expect you to live in a nursing home before I was moving in. But apart from that, I've learned a lot about the system, and it really helped me looking differently. I will give you a few examples. Like here you see my housemate Yul, and here you see my housemate Will. Here you have this little code of the door thing. Here on the right is the door of Ad. He is also my housemate. I will talk about him later, but remind this door. This is the closed ward. We often think in products. If we want to create a better quality of life, we want to buy new products. So what did we do years ago in nursing homes in the Netherlands? We were placing stickers on the door to hide the doors. It's symptom management. What did we do else? The last years we got 2.1 billion euros extra in healthcare. It was 2018, I think. And what were care organizations doing? They were buying new products, for instance, the imagination panels on the walls on the left. And I will give you a short example. Because the idea is that my housemates, while walking under the same ceiling as we have here, and on this type of floor, on the left we had the imagination panel. If my housemates were turning left, they had the idea of walking in the garden, and they could grab a furry of a rabbit or a furry of a cat from the wall. You see them here. And the idea is that it supports people's autonomy. We are often talking about autonomy in visions of care organizations. So this is being sold as it supports your autonomy. But you are all smart people. May I ask you, who of you grabs furries from the wall to get a feeling of autonomy? No, right? This costs like 1,000 euros. It's a product. It doesn't support people's quality of life. It's not reality. We have to be aware that we shouldn't create artificial environments. We shouldn't build care environments. Coming back to the closed ward, I think there's a very hopeful movement going on now in the world, and it will also become stronger in the United Kingdom. Because when I entered the closed ward, I still had that code, 2017. Now in the Netherlands, over 500 care homes have opened up their closed wards. Being locked up based on your diagnosis is not the standard anymore in the Netherlands. Supported by legislation in 2020, supported by the care inspection, and now it's a movement also supported by many carers and family members and people living with dementia speaking out loud. In September, I hosted an event in the Netherlands, and there the Inspector General of the inspection was, and she said, we want to help to push this movement further. Also, we as a care inspection have a role in this. So realizing change, it is not about blaming politicians. It is not about blaming inspection. It is not about blaming CEOs. This is a shared responsibility. We all have a role in this. So the doors are opening, and I will invite you to enter the nursing home with me. May I ask you who recognize this image? Raise your hand, please. Yeah. Some people, yeah. On the left you see my housemate Ad, next to me Ellie, and here you see Tineke. May I ask you another question? Who of you likes warmth? Who of you enjoys the sun? Yeah, almost everyone. Who of you loves to sit outside in the sun when it's, for instance, above 30 degrees? Yeah, right? Never end up in a care institution, please, then. Why? I was living there for 3.5 years, and in those 3.5 years, I never got the key to the garden, because the cultural rule was residents are not allowed to have a key. It's not a rule by the inspection or the government, it's a cultural rule, because we want to have control. We want to know where people are, which doors are open. So the result of that was I had to become dependent, not because of what me and my housemates were having, but because of the system we have created. And we had a heat protocol. I don't know whether you have the same in the United Kingdom, but it's an example. We have a heat protocol, and the heat protocol, it is formed by all good intentions we have to protect people. When it's above 30 degrees, you might dry out, for instance. It's a risk we all have. So the rule, the protocol in our organization is that people can't go outside. The doors stay closed, you can't shower, you get ice creams, you get water on the table. It all happens, we all follow the protocol, but we don't ask the question, does this protocol fit the context we have? Because it's care focused on quality of life. It's care organized by our assumptions, what is a good life? But only good intentions don't lead to quality of life. We have so many good intentions. The whole system of having a closed ward is built on good intentions, but it's not helping people. So we have to reflect on this ourselves. It was fun because you could imagine, as a former nursing home resident, I'm very pleased to be able to drink some water without getting thickener in my drink. But it shows a pattern. Why? I will give you 3 examples. If I have the risk to choke, we might ask the speech therapist for a risk analysis. It's the golden word, a risk analysis. If you hear it in your daily practice, be aware, a risk analysis. If you have a higher risk to choke, you might get the thickener. If you might have a higher risk to fall, then we ask, for instance, the physiotherapist. The physiotherapist will come for a risk analysis. You might walk a little bit, and if you have a higher risk to fall, you might get a walker or something else. A hip airbag is the newest innovation. Or if you might not eat enough, maybe you recognize it, maybe you feel stressed. Who of you start eating less if you feel stressed? Who of you starts eating more? Yeah? Yeah. Can you imagine? You're living in a care facility, you don't feel at home, you feel stressed about it, you are not hungry, and we write down in the medical record, Teun Toebes did not eat enough today. We organize a multidisciplinary conversation without the most important discipline, the resident itself, and we start thinking for people. We ask the dietitian comes, we do a risk analysis, and if you don't eat enough, we call it your intake is not high enough. Your intake. Who of you speaks in the context of being at home about intake? It's medicalized language. We write it down in the medical record, and family members are allowed and they have access to this medical record. So it changes the relations people have. And you might get, if you don't eat enough, you might get thickener, you might get protein drink, for instance. Those small white bottles, you might recognize them. This whole rhetorics, it's not about nursing homes. This is about our healthcare system. I also see it now in home care in the Netherlands, like sometimes people have those whole towers of those little bottles because they don't drink them, because they don't like them. It's a rhetorics in our system, and I don't blame those professionals, the physiotherapist, the speech therapist, the nurses. I don't blame the products we have, the thickener, the protein drink, the walker, the hip airbag. But what I do blame is the way we look at facilitating quality of life in our system. Because we, as professionals, often assume that those professionals or those products automatically leads to a better quality of life, instead of asking someone, what do you need in order to have a good life? And this, dear delegates, is the poverty of our wealth. We have such a rich system. We have so many possibilities that if we don't ask those ethical questions ourselves, the system automatically reacts by protecting people from dying. But that doesn't mean that people also have a good quality of life. So I don't say that medicalization is always bad, but I do say that it is not always helping people and also not helping ourselves. This is my housemate Ad, and we are drinking a beer here. I saw you all yesterday here. Many of you were drinking a beer as well, and we're enjoying it. Who of you has a higher risk to fall if you drink a lot of beer? Yeah, right? Almost everyone, yeah. Yeah. Do you think people with dementia have the same risk? Huh? If they drink alcohol, they get the same reaction? Yeah, right? Huh? They could fall as well. Ad had the rule in his care plan that he was not allowed to drink alcohol during the week, only in the weekends. And the whole background of it, I don't know it, because the decision was made by his legal representative and the professional carer. If the legal representative wants something different than the person living with dementia, to who are we listening? It's the last phase of your life. What really matters to you? And who are we to decide this for people? It's not that Ad and I were constantly drinking beer the whole day. Like sometimes it was 1 or 2 beers, but it was our moment of joy. And I never followed the care plan because I didn't have access to the care plan, because I was his housemate. We were friends. So we could just do it, and it was accepted as well. So I just want to say we have to be really careful with creating our own rules without putting the wish of someone themselves as the central point in it. Ad and I, we really became, I would say, almost best friends. I loved watching soccer with him. I didn't do it before, and I loved those moments of the ritual we had to just see each other in the evening. But Ad also had the shoes, like maybe you recognize them, the typical nursing home shoes. You also have those socks, those yellow and green socks with the white crosses on it for fall prevention. If people enter an institution, they might get, within the first day, those typical socks. It's a form of institutionalization. And maybe we make people more patient than respect them as a human being by this. Coming back to the theme of quality of life, I want to share this story of Jeannette with you. Because I met Jeannette in a nursing home in Belgium. It was a very modern nursing home with beautiful architecture. It was designed, it did cost over 10 million euros, I think. But still, she was laying in bed. I was standing in her door, and maybe you recognize it, but I felt that she was reacting to me. Her breathing changed, and she looked a bit to the left. I didn't know whether she could really see me, but we had a form of contact. So I entered her room, and I saw the prayer card next to her bed. Jeannette was Christian, and I got the prayer card. I started reading the prayer, and by the moment I spoke out loud the first few words, her feet started ticking on the rhythm of the prayer. And by the last words, her feet stopped, and she was sleeping. Still, it was possible to make contact with Jeannette. Still, Jeannette has an identity we could support, an identity of which we could be aware of, which we could see. But if I look in her medical records, I only read about decubitus. I only read about what type of defecation she has, whether it's type 1, 2, 3, 4, 5, 6, 7, what type of shit she has, actually. Type 4 is normal, you might know it. But I'm maybe joking a little bit about the shit, but who cares about what type of shit someone has in the last phase of someone's life? Yeah, sometimes it can be really, really useful to know if you, for instance, have a chronic disease. But it's not useful for everyone. This is about standardization of what we do. And if we standardize those type of measurements and people, family members could read it, they could read every day about the type of shit of their mother, it changes their perspective. The mother ends up as a patient of an institution. And I think we should be aware of this, because this doesn't ask for money and not for new products. It asks from a different way of organizing, a different way of looking at what is really needed in this form of care. And tomorrow I will be working again, and also I have to write down the type of defecation people have. So it is very hard to change this in our system if we are not doing this collectively. Facilitate over organize. Like yesterday I heard people talking about models, but whose wish are we putting at the center if we are talking about models? And by which perspective are we thinking? I heard the word target group so often during my education. What is your target group? We have to stop target group thinking, because the fact that you are living with a certain diagnosis doesn't mean that all your needs as a human being end up in those specific needs people with diagnosis have always. I will give you a few examples, because also here in the room, there is no one who says, I see people as a patient. No one. I'm very sure about that. Everyone has the intention and the approach of seeing someone as a human being. But we also have to recognize that people could feel seen as a patient. This is the living room we were living in, and maybe you might recognize it. Who of you recognizes what we see here? Yeah. Who thinks this is a care environment? Yeah, right? Whose house, whose home looks the same at home? No, right? What do you recognize? Make it as concrete as possible. What do you recognize? Lights. The lights, yeah. Almost the same as here. What else? Chairs, the chairs. Who recognizes the chairs? I think this is fascinating. I'm in England, I'm in the United Kingdom, and you recognize the type of chairs. We are a different country. This is about the way we organize care environments. We are creating environments of unity, not environments based on identity. So we standardize, for instance, the chairs because some people might get help. So we need solid chairs, but not everyone needs help. We give everyone, for instance, a hospital bed without everyone needing a hospital bed. So a hospital bed in the Netherlands, in the context of a nursing home, it costs, for instance, 4,000 euros. A lot of money in our system goes to standardization without it having the aim to support the quality of life. This is also a solution within the system. What you see here as well, you see that we have this lighting. We had biodynamical lighting in the nursing home, and the biodynamical lighting meant that if it was light outside, it was light inside. If it was dark outside, it was dark inside. And as a nurse, I never ever saw it, but as a resident, I had a different expectation. Because I was sitting there in the winter, and I experienced that the biodynamical lighting was set up in summertime. So it was 8 in the evening, and it was still light inside, while being dark outside. I will do some reasoning with you. What happens if someone, for instance, with dementia is being brought to bed, and you are sitting on the side of your bed? The carer lies you in bed with warmth, with compassion, and you're laying there. If you are just coming from the bright light, who of you is able to sleep directly? No, right? So you might step out of bed, your sensor goes off, people start looking, the carer takes you again in bed, and again, and again, and again, and the carer gets frustrated. Who could imagine that? I can imagine, yeah. So the carer might write down in the medical record, Teun is not able to sleep. We come again in the multidisciplinary conversation, and we might think in products. We might give me temazepam. It works 6 hours. We give it at 8, 9, 10. Someone wakes up at 2, 3, 4. You wake up. You don't recognize the environment because it feels like an institution and not as a home. You see a little bit of light. You start walking. What do we call that? How do we call that? Walking, when people with dementia start walking. Wandering, indeed. When I start walking, we call it walking. When my housemates start walking, we call it wandering. The fact that we know that someone has a label automatically leads that we define the behavior of someone in a different way. And is that helping people? I will give you another example, because this is the nursing home in Utrecht. Now we will go to the east of the Netherlands, so a totally different organization with a different CEO. Look at the similarities. You see them? I think it's fascinating. What is the similarity? The chairs. And what else? What else? Does someone recognize the colors? The colors, you see them? So you have orange chairs with green elements and a light brown floor. Disease thinking, we are often unaware of this. And I don't blame people for this. But disease thinking is, or target group thinking, it is sometimes in the core we organize healthcare systems. Because a CEO of the care organization did ask an interior architect, please design an environment for people living with dementia. So the interior architect specialized in people living with dementia, started reading a lot about dementia, started reading a lot about the problems. I learned at my education that Alzheimer's dementia is about a plaque in the brains, but I can't help out with it by knowing it. So what is our focus? The interior architect discovered that bright colors might lead to more aggressive behavior. So the newest nursing homes in the Netherlands are all designed by pastel colors. But the fact that you live with dementia doesn't mean that your favorite color, which might be bright red, changes in, for instance, light green. So the way we organize those environments really is core to people's behavior. And I think no one wants to end up in a care environment. You want to end up in a place which has a feeling of security. And a feeling of security is a different aim than security in the form of a code of a door. It's a different form of security. I will give another example. Who of you recognizes this trolley? Yeah. You might recognize the stainless steel trolley. I think it's the ultimate symbol of institutionalization. We also have the stainless steel coffee and tea cups. I think I hope in the United Kingdom it's different because tea is such a big part of your culture. But in the Netherlands it's different. So we have those stainless steel pots. We have black for coffee, yellow for tea. And we see the same in education institutions. We see the same at municipalities. We see the same in care institutions. So there is no single rule in the Netherlands which says, please have stainless steel coffee and teapots. It's just the way we organize. It has nothing to do with dementia. But could you imagine, who of you at home, who of you has a great teapot? Who of you is proud at their teapot at home? Yeah. How amazing is it if you are allowed to bring your own teapots, that you see that other people get tea out of your teapot? It might seem like a small thing. Maybe you're thinking, now Teun, we are at Nuffield Trust Summit, why are you talking about the teapots? Like we are big systemic thinkers, but if you're defining this as a small thing, it is your privilege. Because if you're living here, it might have a huge effect on your quality of life. Because it supports your identity. And in the core, it's all about supporting identity. This is a beautiful example because together with Jonathan de Jong, the film director, and I, we started looking for different initiatives in the world. And we discovered this place in Denmark where a living environment is at the core of the organization. So at the nursing home I was living in, we only had plastic plants. Does someone has an idea why? It's not the microbiologist in the hospital, it's because people are afraid that people with dementia start eating plants. So it happened. The quality system of our care organization said that if an incident happens, that for instance, if someone eats a bit of a plant, we have to do an incident report, and then someone in the department of quality starts analyzing the incident reports. But the question is, what do we define as quality? Do we see quality of care as safe care, means quality having 0 risks, or is it something different? In the year I lived in a nursing home, we did spend over 10,000 euros on plastic plants. We could do a lot of beautiful things with 10,000 euros. And why is this important? My housemate Eugenie, for instance, she was born in Indonesia. She was born in the jungle. She loved a green environment. And she was always taking care of my plants in my room. If we create a dead environment, we have dead people. They did it different here. They had real plants. They even had a real dog in the home. And this was not called a therapy dog, no. This was just a dog. The dog had a name. Playing a game is not called brain gymnastics, it's just playing a game, right? Yeah. And they also had fire. And I think the fire is fascinating. I don't say at all NHS places, please build fires, huge fires, because then we will have a problem. But what we are doing now might also not be the solution, because now we often say fire in all forms is not allowed in all organizations. I was celebrating Christmas 3 years in a row on the closed ward. 3 years in a row with a little candlelight on batteries in a plastic cup. And on the television we had the fire, the wood fire, on YouTube. It's a different feeling. Yesterday, my own grandma passed away a year ago. She was living with dementia, and I remember she was laying in the hospital, and the pastor came to her and took out the candlelight on batteries, and she placed it next to her. This is also an example of the poverty of our wealth. Because what are we afraid of? My grandma had morphine, she had dormicum. She wasn't coming out of her bed to eat up the candle or to burn the curtains. So if the fundament of our care system is thinking what if or yeah but, we organize places which are not supporting everyday's life. And in its core, I think that's the main request of many of the housemates I have lived with. Living environments. Looking differently at quality and being able to facilitate also requests us to reflect on our idea of what is good quality. Maybe you could ask the question yourself. Who of you would define this as a good quality? I won't. I was standing here. This is in Moldova. It's the poorest country of Europe. I saw this place. I was here 3 times. And when I looked up, I saw people being outside in a cage. And I thought, this is a prison. My idea was, this can't be a good life. But this is my assumption. Our cultural assumption is often, if we build beautiful places, people have a beautiful life. But you can experience a horrible life in a beautiful place, but also the other way around. So don't judge only about what does it look like, but go inside, experience, feel, what does it do with you? You go in, and what did I see? Next to me you see the psychiatrist. This man, he worked so relational. He worked so relational. He was Such a great man here. I was often sitting here on the right, and I looked to the end of the corridor, and I saw 2 residents helping another resident to the toilet, which was at the end of the door. And the only thing I could think is, oh my God, if they fall now, I have to write 3 incident reports. I have to follow the fall protocol. I have to write down what type of shoes people were wearing, and a quality staff member is going to analyze what I wrote. But they were bringing each other to the toilet, they came back, and later I was eating with them. I was sitting next to them, and it was so beautiful. I saw them helping each other with eating. If people didn't have the capacities to eat themselves, other residents were helping them. And the only thing which I could think is, wow, in the Netherlands, your neighbors, we need a certificate to be allowed to bring people to the toilet. You need to have a certificate to be allowed to help someone with eating. We often see this as tasks for professional carers. But if we put living together at the center, shouldn't ask it from us to look differently at what is the definition of a professional carer, and whose responsibility is this? I don't say copy Moldova, that's not my message, but maybe we could learn something from it. Last example about this, and then I will go to the last part, is the way people were living here. I was living with beautiful people, with Ad, with Tineke, with Ellie, but all people living with dementia. All people sorted by the care system by their indication. So I was living together with people with the same indication. If you all have the same needs, if you all have, if you are all sorted by the unity based on a care need, then you can't help each other. So if we want to facilitate people, we need a more diverse environment. If you really want to support communities, we need to facilitate people in order to live together in a better way. And that's not possible if we exclude people based on their indication. And even though I still work in long-term care, even though I lived there for 3.5 years, I personally don't believe that nursing homes itself as the form are the answer to a better future. We need more social forms of living, where someone's care indication is not the only entrance ticket to be allowed to live somewhere or not. Because the financial incentive in the system in the Netherlands is if you become more sick, you get more money. So what do we see in the Netherlands? That thinking through the lens of someone's care needs is supporting the financial resources in the organization. I don't say that's always bad, but if someone's care need is the only financial incentive, we can't expect care organizations to support communities in a better way. And the last part, I so strongly believe in humanizing people like you and me. People with a certain indication, people with a certain diagnosis, and we have to break down the stigma. Maybe you are aware of this now, but I haven't spoken about dementia so far. I spoke about the way we organize systems. The way we organize systems based on the idea that people are often seen as the other. Talking about the stigma of dementia, I also had a very stigmatized view. I thought people with dementia are only losing. Stigma is not created by God, or it is not, it wasn't born during the Big Bang. Stigma is our social construct. We could change this. And I will give you a short example. This is a campaign of our Dutch Alzheimer's Association 2 years ago. You see family members holding the pictures of their loved one living with dementia. Most of them were still living. And the slogan says, dementia makes you lose yourself and each other. I think dementia, I don't wish anyone dementia. Let me be very clear. Losing can be an experience you face. I also experienced it with my grandma. But there's a difference between an individual's experience and the responsibility of important systemic organizations. If you claim to be the voice of someone living with dementia, it comes with a huge responsibility. And we should be aware that we don't make dementia a social death because of the stigma we create. Because on the other hand, we say dementia makes you lose yourself and each other. We build a stigma. And on the other hand, we are having campaigns to destigmatize people. And we have to break this self-fulfilling prophecy. I so strongly believe, and this is not about dementia, dear people, I so strongly believe we need strong patient organizations. But based on a narrative which is helping people who are living now with a certain diagnosis, and based on a narrative which is honest, which is nuanced. You can't say that dementia always makes you lose yourself and each other. You can't say that. Are those people losing themselves and each other? Or, coming back to Leah, is she losing herself and each other? Many people living with dementia, with whom I've lived with, and also who I've met in the world, told me that dementia can be really painful. Really painful. It can change your relations with each other drastically. But what's even more painful is the way our society starts looking at you from the moment you receive your diagnosis. You're not more seen as one of us, but as the other. And that's something which we could change ourselves. And that's also what makes dementia a societal issue. Thank you so much. Thank you.
Thank you so much, Teun. Can you take a seat?
Yeah.
That was incredibly moving and thought-provoking and really quite challenging, I think, for me, and I'm sure many in the audience, and I'm buzzing with sort of questions and thoughts. I think it's, obviously you've touched on so many themes that get to the heart of our health and care system, and a lot of the themes that we talked about yesterday, but shining a slightly different light and looking through a slightly different lens. You've touched on the tension between the medical model and the individual, and keeping people safe and fulfilling life. And I think it's, obviously you've focused on dementia specifically, but I think those are questions that have broader relevance to our wider health and care system. And I think it's really a really timely point at which to be challenged, because we heard from Baroness Casey yesterday about an ambition to create a new care system. And as she reflected on, awareness of what even social care is really low. But we need the public to be on board and to understand what social care is in order to have a conversation about the future of our care system and how we support people. But what we need is, just to say, I think what we need is, as you've been saying, we need a social and cultural shift in the way that we think about things, and a clear narrative about what we want to create in our care system. Do you have any reflections on that?
On what?
On that, creating that cultural shift, and your perspective, having been on this journey now for 6 years, it feels like you have started to make that change, and you've had some impact. What do you think it has led to that impact? What's been successful about where you've...
I think we could change by creating fear, and we could change by sharing hope. And we all get more inspired if we share hopeful examples, if people get the feeling that it is possible to change, because it is. We see it already. Like everywhere in the world where I've been, for the first film we traveled to 11 countries, the second one we are going now to 14 countries. Everywhere, also in the United Kingdom, there are so many people striving for quality of life, also here in the room. But also so many people working in the system you also might be, some of them, are feeling frustrated by the system. So many people feel powerless by the system. Like, can we really change? I'm only this person, I'm only this person. But yes, we can change if we are embracing each other based on central themes we want to realize. And that's really what I've seen in the Netherlands. Also, for instance, when it comes to opening the doors, I think it's such a hopeful movement that also the big care organizations are now leading this movement, because so often we don't want to change the system because we are getting uncomfortable with change or the questions which will pop up. But it is about not blaming anyone else if an incident occurs, that you start looking for who is guilty, but that you start having a conversation based on the vision care organizations have. And I think you all know care organizations with a definition or a vision. We are here for person-centered care. You can live like it's your home. We think you're still seen as a human, but vision only gets meaning if we realize it in practice. So I think that's my biggest reflection. If we take that as a force to change.
Okay, so a message of hope and a vision of hope, I think is what you're saying. Can I just pick up, I think, what is the dominant theme in what you were saying, and what I think is the most uncomfortable tension that we're talking about here, is this idea of risk. Yeah. And we all work in this medical model of where we have a moral and a legal duty to keep people safe and to avoid risk. And what you've sort of set out is that that can be in direct tension with people living a fulfilling life. And there's a quote from your book that I liked where you've said, "We've gone too far in our efforts to care for people and we've lost sight of how to best care about them." How do you think, we're in a room of people many of whom's day job is to keep people safe and to avoid risk. How do you suggest we balance that tension? You're a practicing nurse. How do you sort of carry those two things?
Let's say your legal responsibility, if that's the excuse to protect people without putting people's wishes at the center, if your excuse is we have legislation, then please speak about it. Maybe you can change this, because change doesn't come from legislation itself. Also legislation is the product of our culture. So if this is such a strong cultural shift, we also need people who make the legislation in this. And I think so many people, it doesn't matter in which layer of the system you're working in. Also my direct colleagues, they also face huge challenges with which risk do we accept and which risk we don't. But the most important is that we start talking about it more than we do now. And the assumptions we have to question them. Why do we do the things which we are doing now?
Thank you. I wondered if we could maybe go out to the audience with that question, because I think this for me is like the really interesting point for people here. Oh, we've already got a hand up over here. Thank you.
Rebecca Rose, and I'm a doctor at the Community Hospice in Greenwich, and my question completely follows up on this. So within the hospice, our role is to manage people's symptoms and what I think of as curating the end of their lives in line with their wishes. And one of the things that we often come up with is that what the person living with cancer, our kind of the person to whom we have primary duty of care wants, has inherent risks in it. And that might be, I don't want to move my bed down into the sitting room where there's more space. I want to stay upstairs sleeping, but I might fall down the stairs. And the tension that we have is that their kids often say, you can't do that. It's too dangerous. And they can't cope with the risk. And we manage and support those conversations. That's part of our role. And I'm really interested in what you said about this group of patients with dementia who may not have that capacity to understand the risks that they are potentially putting themselves through, and how their kids, their carers, the person who's got power of attorney, then has a judgment over that risk. So I've kind of got two questions for you. One is, has there been anything done around advanced planning that goes further than we currently do now and that really builds in an advanced statement of somebody's risk appetite. So I think that'd be very interesting. And then the other thing which I think you brushed over is that I love the way you challenge risk and talked about letting people go out into the garden. But we heard yesterday about care homes operating on a shoestring. If one of them goes out and falls over, that's probably 2 members of staff in A&E for the whole afternoon. And the organisation has to have some, there has to be some consideration, I think, for the resource issues around opening up risk. And I just wondered if you'd ever thought about how you might manage the tension between individual and institutional needs as you think about redefining risk. That's quite long, I hope.
I will respond to the last one, and then you have to remind me to the
Yeah, I've written it
down. The assumption is that if we protect people, that there are fewer risks. But if you're constantly protected, my housemate Tineke, for instance, she always said, if I'm moving a bit, they already start coming to ask me, where are you going? Like, she didn't have a feeling of autonomy. So she was sitting the whole day in the couch. She was losing all her muscles, because we constantly want to protect her. The question is, if we are so much focused on having 0 risks, does her life really get safer? Or are we making her more dependent and so less safe if she starts walking to the garden with a carer next to her? So I think this is the challenge, the question we have to challenge. We have also been in an example in the Netherlands in the south, and they didn't have an elevator. They just had stairs in the nursing home with a small chair on the stair. I don't know what you call it in English.
Stair lift?
Okay, this. And the result was that, maybe you sat on such a chair as well, that all the people in the home, they didn't want to sit on that chair because it didn't feel very safe. It didn't make them comfortable. So their natural behavior was to still climb the chairs. And then it's up to the care organization to stand for their vision if something happens. That's the most important. So also the role of a leader, leading a care organization in a system based on control and safety is not the most difficult. We have enough patients often in the Netherlands. I don't like the word patients, but you all use it, I heard. So that's not the most difficult. The most difficult is to question your existence as a care organization. What is your vision? How can we support this as most as possible? How can we adapt to the changing societal needs? And the older persons from 40 years ago might have different needs than the older persons from now. They were born in the hippie time. They were in the Netherlands smoking weed and I don't know what, but it was a different lifestyle. So people also have different needs. And maybe you have to ask a more existential question to yourself, like, do you rather have the possibility to go out with knowing that you have the risk to fall because you still have grass? Or do you rather be bound to your chair and not having the freedom or the possibility to move whenever you want? And this is very black and white. I know reality is not black and white, but maybe it opens up also the responsibility of leaders to facilitate and to... yesterday I heard someone saying the response, I have your back. Who has your back? The sir in the evening said it. Who has your back? That's a very important question. And I think I am so hopeful, even though...
Rebecca, do you want to come back on that? I could see you point.
I think one thing that, I don't know what it's like in the Netherlands, but there is the person that you're caring for, and then there's the context and the relatives around them and the family around them who respond, can be litigious, can be complicated. That shapes our behaviours as well. And what I was thinking as you were talking was, I'd like to see a system of red, amber and green rated riskiness of residential homes. And you can kind of take your pick for your own relative hopefully knowing what they would like, but also what you can cope with. And I would probably want to be put into a red risk nursing home where I could go out and trip over in the garden, but I know plenty of people who wouldn't. So I just think
but the fact that you live with dementia doesn't mean that you get stupid. So it doesn't mean that you don't have any sense of risks in your life. Of course, it has influence, or it could have influence, but it's too nuanced to say that everyone with dementia doesn't have any insight of their risks in life. Like, I heard the minister in the Netherlands saying a few years ago, we have to be really careful with opening the wards because you don't want people to start walking on the whole highway, or you don't want people to end up in front of a bus. But this is not reality. It is not that if you open the doors that people massively walk to the highway and start sitting on the highway. Like, of course, it could happen in a very, very, very specific situation. But it doesn't mean that all people with the same diagnosis have the same behavior. So that is the tension between the collective and the individual. I think there are two intersections. So collective and individual, but also safety and control, the system based on safety and control, and the system based on quality of life. And the safest, the most easy is to be focused on safety and control and on the collective. But it's also up to us as people in the system to navigate us to a system where there is more balance. Like, I never say that safety of people is not important, never ever. But it is about a more balanced system between safety on the one hand and quality of life, being allowed to face risks in your life on the other hand.
Okay, thank you. But I think Rebecca is touching on something
but
about...
But I will come to you later.
the wider context in which people... It's not just the individual, it's the family, it's the system, it's the pressure that care providers are under. I see we have another hand up over here. Can we take that? Oh no, we'll come back to Rebecca's first question, which I've only just remembered.
I'm very curious to what he thinks.
Okay. Please.
Thank you very much. I'm Dan Alton. I'm Chief Clinical Information Officer of Buckinghamshire, Oxfordshire and Berkshire West ICB, and a GP. And thank you for that fantastic, insightful talk. It certainly resonated as where I worked previously, we were a GP surgery covering a very large nursing home. And I remember one particular incident where we were contacted by the nurse in charge saying a particular patient was desperate for a small sweet sherry every evening before dinner. There were no medical reasons she couldn't have the small sweet sherry, so I said, absolutely fine, it'll improve her quality of life. A couple of days later, we were contacted again saying, can you put this in writing? So we put this in writing. About a week or two later, we were contacted again saying, can you put this in writing and sign it? And I think that absolutely perfectly exemplifies the issue of risk and who's got whose back. The nursing home had protocols. They were concerned that if this patient fell over after the small sweet sherry, they would be blamed. But the irony is we're facing a similar situation as David Haslam mentioned yesterday, with patients repeatedly from nursing homes ending up in hospital when they are often much better served at home in the nursing home, being cared for in a place that they would like to be cared for. Even better if the nursing home is even better, as you mentioned. We are thinking about neighbourhood health, as you might have heard. So we may have an opportunity here to improve how we do things out of hospitals. Because if nursing homes are challenging places to live, spending your last few days or weeks or sometimes months in an acute hospital certainly can be even worse. And morally, we need to be considering this. Advanced care planning can clearly help, but what I've observed is advanced care planning is sometimes done as a tick box exercise. To do it properly takes a huge amount of time to really understand that individual as an individual, and that's quite a unique skill set. So given the fact that we're considering neighbourhood developments and how we can change the way we do healthcare, have you seen advanced care planning done to really understand the wishes of that individual in a way that has managed to overcome that tick box culture and actually allow risk to be taken? And if so, in all of your observations, how was that achieved? Thank you.
Great question. You want to
Great question.
have a go at that?
Talking about advanced care planning, I didn't expect me to talk about it today. I don't have a very clear opinion about advanced care planning. What I see in practice is that it could really work, but only if it is done by a culture which really wants to put people at the center. And your message about the berry, it strongly resonated with me because it shows a different culture than putting someone's wish at the center. So speaking about neighborhood care, it requests from hospitals to don't take the hospital culture to the neighborhoods itself. Because in the Netherlands, I see that happening now. And there are also many people aware of this, so there is also a counterforce coming on now. There are many people who are working on this, really great. But we started taking away carpets from people at home because we thought, oh, people could fall over the carpet while they had this carpet already laying there for 60 years. Mm-hmm. So I think this really requests from us to be aware of the culture we have. Like neighborhood care is very difficult. We make a second film about communities in the world. Having community at the center doesn't ask from care organizations to have a community builder, which is a professional carer often, going around to the neighborhood and sorting people because of their indication. So also related to the advanced care planning, in the Netherlands it's mostly part of the GP, the GP of people, because they work the most relational in the care system. And I think that's a very great example. Yeah.
Okay. Thanks, Teun. Right, we have a cluster of questions over here. Can we go, person in the red?
I'm curious to the pediatrician
one there. Can we
well.
Can we take maybe?
I'm like very curious because you work in a hospital, so.
Yes, please. We'll take maybe two. Should we take 2 or 3 and then
I have the time.
wrap them up?
Hi, Teun. Sarah from Mind. And look, I wanted to laugh and weep as you were speaking, and thank you so much. I have to say you are extraordinary. It did remind me of, I also lived in a therapeutic community for a year with people with serious mental illness in the 90s, and it taught me something about compassion. It taught me something about how I relate to others. I guess one of the things that came up very much as you were speaking and in these beautiful videos, which are beautiful, was the intimacy between you and the individuals, and that intimacy is incredibly important in the caring relationship. The reality is that in care, and we see this resonates really very much in care for people with mental illness as well, that that intimacy is kind of trained out of us, right? It is, and because of risk, because of boundaries, and safeguarding, right? And all of these things constantly are raised with us in relation to how we're engaging with other people. And then the flip side of that is we have an increasing number of complaints about staff, right? A lack of compassion, and we've got these wild compassion initiatives, which everyone drive me up the wall, right, just saying. Because the idea of saying to people, can you just be more compassionate on the ward or more compassionate in the care home? Because I think there's a compassion privilege, right? When you're working in care homes and you're having to write those 3 reports because those people have gone to the toilet and fallen over, also being compassionate and intimate and caring is a really difficult balance, right? Yeah. So what do you think of that? I mean, I every time somebody talks to me about compassionate leadership or compassion initiative, we're helping our workforce, I kind of just want to go like that, because nobody goes into this work, not wanting to be compassionate, right?
No,
but
exactly.
Compassion and intimacy are drained out of us.
It's organized away. I will give a short reflection due to the time. Maybe we can do another question then. But you saw the example maybe on the screen. There was a carer laying next to someone in bed, and we should be aware. Don't write a new protocol. First step: start laying in bed next to someone 5 minutes, because then we are instrumentalizing compassion, and that's when it goes wrong. Because it's not just an instrument; it's part of who we are, and this really comes to what do we see as being a good carer. When I started my education, my first learning aim was to be able to wash a mid-complex patient. I would never say this again, a mid-complex patient, like what are we talking about? And I wanted to learn how to wash people. I would never do this again. My first learning aim now would be to sit, it has to be smart, so the first week of my internship, to sit next to residents and to listen, to feel, to hear. And if I'm listening, what do I hear? I constantly hear keys. By the tickling sound of the keys, I can hear who is approaching, whether it's the coordinating nurse, they have many keys, they have many power, lots of power, much power, sorry, or whether it's the person working in the living room. Keys are not a symbol of compassion. It's the same with all those identification cards. Sometimes people are sitting next to someone and they place their identification cards next to them on the table. You directly have a difference in your role. You have a power imbalance. This is really about power imbalance. Also, if you want to have compassion at the center, last example, if you sit there, if you look around, I saw, and it still is, I saw that the carers in the nursing home I was living in had different coffee. They had cappuccino. The coffee machine was standing outside of the ward, and they came back with paper cups with the logo of the care organization. Who of you has logos in your home coffee cups? You don't have that. So we create differences. This is not because carers want it, but they are working in a system which is organized this way. So if we want compassion to put it at the center, it's about a different way of organizing and facilitating. Go to the same toilet. I had a different toilet as a nurse than I had as a resident. And the first moment, you could all imagine, I was taking a shower in the shared bathroom, and I was having the shower, and the door went open, and the carer was standing at the door, and they got like the pink, I don't know what to call it. They were embarrassed, yeah. And the thing I thought is, why are you embarrassed now? Because we often see it as normal to just open the door if a resident is there. And why is the door not able to lock? Because safety. Because if someone falls in the room, we have to be there directly. This doesn't create a compassionate environment, and that's what we should be focused on as well. So a question to you, do you drink the same coffee at your office or at your workplace as the residents, the clients, the patients you are serving or you are helping?
Thank you. Right, I'm aware there's a lot of hands up, so can we take maybe next to you there, and then at the front here and there. Let's take 3 and then collect up.
Hi, I'm Claire Goodman, academic, done a lot of work in care homes, and just thank you. This has been such a powerful presentation, and people are not going to forget this. And one of my mantras is no stories without numbers, no numbers without stories. So you've given us a story, and then you've challenged what we count. And I've just completed a study looking at what's the minimum data everybody would need from health, from social care, from the regulator, that would actually be compelling. And of course, the history of social care is they've never had data to bring. No. So it's always been the health data. And and Baroness Casey said it's not a system. And boy, it's not a system with independent businesses all collecting the data they want. So that's my reflection. But we did a national survey of care homes in England. And we absolutely, we found that of their measures, the measures they used, almost all of them are using the Bristol stool chart. Very good. Yeah. 25% were using some measure of quality of life, but it wasn't standardized. So this brings me to your point of where you're pushing a bit about standardization. So one of the things we did was we introduced a care-related quality of life measure into this minimum data set that went into the digital care record. And we're on the cusp. Social care is digitalizing, so we have an opportunity. I have to say that the system used in the Netherlands, Intereye, doesn't really address quality of life in its huge number of questions that it asks. And it's a validated measure, some people will know it, of do you feel you have choice? Do you get involved in decisions? Do you feel valued? Do you feel you are treated with respect? Do you feel you have dignity? and it's the resident. It's not what. So there is a proxy measure. So we tested whether there's gaming, and actually the staff found it a huge responsibility. So that's the story. The number. So we were able to show, you can introduce this measure, you can put it into routine measurement. But the question is, how do they use the data?
Yeah.
Okay.
Yeah.
So obviously, the point I'm making is that where staff were supported to use the data, they made the comment, we are obsessed with advanced care planning to make sure we reduce unplanned hospital admission. We're not obsessed with asking, how are you today?
Yeah.
And then out of that came the revelation of this person wants to go out. This person wants to have a choice. And it was transformative, but you needed the staff to have the authority to act on the information they collected.
Okay, so
I fully agree. I think it's not a question, but I fully agree.
Yeah, can we take
I also think we also need data. So it depends. The question is, what is the data serving? Like, with what is the data helping?
Yeah, and how do you
I think this is also the culture. Last thing, Natasha, sorry. But this is also the different culture. Speaking about yesterday, the reform of social care. Social care has a different identity than healthcare. So in this reform, we have to be aware that we don't copy the culture from healthcare to social care. And that also depends on which data do we want to know. And I think that's something we should really be aware of, because yesterday I also heard that the sentence like dementia is going to be the leading death cause. That is language we will never ever use in social care. Never. So it almost seems like we are striving to have the leading death cause, then we are there, but it's not the character, the identity of what we in social care stand for.
And in that, you've just opened up a whole new theme around integration and clash of cultures. But let's hear from Andy.
Is this on?
Oh, yeah, it is now.
Hi, I'm Andy McCabe, a co-convener at Social Care Future, and it's really beautiful to hear you talk about hope, because I think there's been a lot of hope missing from this conversation. And I'm part of a social movement that actually would coin the phrase that we were born of frustration but powered by hope. I think your talk of risk is spot on. I mean, I think a lot of what you said was obviously amazing to hear, because I think we are happy for people to be in a care home, that the risk might be that if they're not allowed to get out of their chair, the risk is very high that they'll get depressed and mentally ill. And that's an acceptable risk, but it's much worse if they get up and fall over. And I think that speaks to the quality of life points that you raise. A couple of the questions I've heard, I think, talk to almost tinkering around the edges in the current system we've got. My view, and I think what you're expressing, is that we need a cultural revolution to change the way that people understand and value human beings. So a simple question for you is, a couple of questions is, how have you managed to express that to people that gets people on board with your vision of what I think is a cultural revolution to improve people's lives? Strongly, I can see you've made a film. Would you recommend media as a way of doing that? And my final question is, do you have any recommendations to the Casey review as to what she could embrace as what is really positive and good, rather than the crisis stories that we hear? And thank you.
I think that's already the answer. But, okay, help me please, Natasha. The first question was... Do
you want to start with the
no,
social revolution?
First.
How do you get people with you?
That was very difficult, because, and you also might think it now, who is this direct Dutch person this morning talking to us? But also when I started living in a nursing home, I constantly had to say also to the carers, I'm not here to attack you. I'm not here to blame you, because I'm not focused on the individual's responsibility, but more on the system we have created, which we are part of, and how to change this. And if you could make people comfortable with their position, knowing that they are part of the problem, but also part of the solution, that really helps to make them fight for the same cause and do it together. So the film, I made it together with Jonathan de Jong. Without him, it wasn't even possible, not in a single moment. So if you work together on changing a narrative, then I think that's the most powerful tool. We really have chosen consciously to make an inspiring film, because the easiest thing to do was to make a horrible film about dementia. It was so easy. It doesn't ask 150 days to film, but you don't help people with only telling a sad story. You don't help anyone living now with dementia. So we wanted to show people how it could be done differently, and if people see it, if people feel it, then people don't change by their rationality, but by their inner feeling.
Thank you. And do you have any particular recommendations for Baroness Casey?
I think what I said about the culture of social care, to be really aware of the culture it already has, and that we shouldn't copy cultural elements from the healthcare sector without questioning them in the context of social care.
I think we have time for maybe one, maybe two questions. Can we have Crystal here?
Can I ask? Yeah, Ben. Oh, sorry.
And then, okay, and then that one. We'll ask one.
Thank you. Thank you so much, Teun. That was really, really interesting and challenging for all of us. So I'm Crystal. I'm a Nuffield Trust trustee, and I'm also a community nurse by background. And I have a 90-year-old mother in a care home. So a lot of what you, with dementia, a lot of what you said resonated, although I would love you to come and see her home. She is cared for beautifully, and the risk is managed through the relatives as well. So I get a call when she's fallen.
Yeah.
Do you really want us to call 999? So thank you very much, and we manage it between us. But that wasn't my point. My point was about nursing. And you've spoken a lot about needing a cultural change and the way in which society looks at dementia and cares for people. And I'm interested in the nursing profession and what impact this has made to the nurses who work in care homes in the Netherlands and other places that you've been, but particularly the Netherlands. And I've done some work with community nurses in the Netherlands, not in nursing homes. In the UK, the status of a nurse working in social care is considered, I think it's fair to say, my nursing colleagues in the room, to be less than a nurse who is working in the NHS or in healthcare.
Yeah.
So my question is about how is the impact of your work landing with nurses who work in the system of nursing homes and social care?
Yeah.
Thank you.
Thank you. Take that, and then we'll
let me highlight two things. Sorry. It was received at the beginning like a threat, but now my colleagues are the biggest supporter. Like at the event about opening up the wards, 2,500 colleagues working in care homes showed up to be part of the movement. So they are part of what we want to change, and it's now received really well. Also on social media, I'm very happy about this because it was very frustrating sometimes. It's really about how to tell a story. But talking about the status, this is not a status which does just come from social care. This is a social inequality supported by the system we are all talking about. If I look at the Netherlands, like nurses in social care get paid way less than people working in an academic hospital. But the question we have to put at the center is, where is the value of a nurse the highest? And is one nurse in a clinical environment, does it have the same value as one nurse in a neighborhood? And if we always talk about communities, I hear it already for years, even though I'm not that long in the sector, but it also asks us to question those inequalities and to change it, because we are too comfortable with having the academic hospital, for instance, in the Netherlands as the top of the hill. Yeah, that's all I want to say about it. I think
all right,
it's clear.
thank you. I think we've got time for one last question.
Thank you, Teun. That was really, really thought-provoking and very inspiring. My name's Nathan. I'm from the National Care Forum. It's a membership body for not-for-profit care and support providers, so firmly in the adult social care space. and going much beyond sort of just your nursing and care homes, thinking about services in the community and very bespoke services that are formed in local communities. I'm also coming at this with this question with another hat on. So I've got a relative in a nursing home and another relative receiving health and social care in the community. And this builds, I think, quite nicely on the last question. You know, if we're talking about nurses in social care, being that sort of that inequality you talked about, being treated as less than, frontline care and support workers are at the very bottom rung of, I think, most professions in the UK, the way they're regarded, the way immigration policy is applied to them, and the way they're treated and paid for. They're not regarded as skilled workers, despite the highly emotional and relational work that they do. So I'll get to my question in a second. We've got an issue with how we perceive care in this country and what it means to care for people. It's seen as a non-skilled profession. Maybe two questions. How do we start to change that approach to things? And secondly, how do we empower our frontline care workers, whether they be in a nursing home or care home or working in the community? How do we empower them to actually start to change and shape the systems around them? And particularly when everybody else is looking down upon them. And I'm sorry to say, many NHS colleagues look down upon them as well.
Okay, thank you, Nathan. Right, can we have a brief answer?
Brief. I hear your message. Yeah, brief. Changing a narrative really starts with the positionality you have. So you say they're being looked down on them. As a resident in the nursing home, I was looking up to them. So during COVID, when we as residents wanted to raise our voice, we had to go to the client board, all family members, or we had to go to the carer. So how you ask the questions really departs from your own position. Who of you thinks that we inspire or that we make the status higher by constantly speaking about the problems in social care? If we constantly repeat, it's also very easy to make a film about how difficult care is, how hard the working circumstances are. It's very easy. But in the end, we don't help changing the system. We only confirm a reality. And I do not want to be unrealistic, but it's and. So it's good to say the problems, but next to that, you also have to highlight what could be done differently. And I think that's the most important when it comes to changing the status. The core is always relationality, always. And we had a social worker in the nursing home. His name was Niels. And I didn't even had to know that he was there. I could feel it by the behavior of my residents, my co-residents. Like, if he was there, he worked so relational. He was sitting there reading a newspaper, but my housemates were out. They were walking around. And so I heard life in the living room. And it's really about revaluing the position of relationality in our healthcare system.
Okay, thank you very much. I think we're just about out of time, and we need to let people go and have caffeine.
Yeah.
That was incredible.
And the question is then, are people in the nursing home after 9 allowed to drink coffee with caffeine, or are we giving people coffee without caffeine?
Yeah. Thank you for such a thought-provoking and memorable session to start us off. Thank you. And I mentioned